talking about the different cataract situations, how to deal with it.
Okay, so I'm going to talk to you about different variations of technique in cataract surgery. The idea being to be able to make your surgeries work very well. So the first point I want to talk about is this picture here where you see I've broken the lens, the first fracture, in two pieces, because I think that we really should not sculpt. When you sculpt the lens, you basically are pushing against the zonules. And so even if you're very good at it, you're inducing damage to the zonules and having lots of extra flow of fluid in the eye. It may damage endothelial cells that you really don't want to have. And so chopping is a much better way of doing surgery. The problem with chopping is the first chop. And so you see here, I have a phaco-tip sitting in one side of the lens and a chopper on the other side, pulling them apart. How did I get to that? Well, what you want to do is you want to take the phaco-tip and bury it into the center of the lens, actually just a bit past the center. So if you look at it from a side view, it would be like this. So you've gone, if the center is here, you've gone past the center a little bit in all directions. And the reason is, when you put the chopper and you run it along this line, you want to be able to cut the lens, but not rotate it. And so if you don't go past the middle and you put the chopper here, the lens will tend to rotate. Whereas if you go past the middle and you have the lens basically impaled on the chopper, on the phaco, you'll be able to cut it very easily. So I'm going to first show you a video. This is a video that I made a number of years ago about a technique that I called phaco slice and separate. And the idea was that we should look at chopping lenses not as chopping them, but as slicing them as if you're slicing bread. And the reason is it's more gentle. And you want to do surgery gently and not aggressively. So I'll just play this video and it has sound, and then after we'll discuss it a bit. Okay, so here we go.
My phaco technique of slice and separate is demonstrated here in my ultimate soft shell technique. Slice and separate was adapted from the previous techniques of Nagahara and Fukusaku, with the main difference being that the nucleus assembly is performed in a manner similar to slicing bread, with the goal of creating a more gentle procedure applicable to a wider variety of nutrient densities. In the ultimate soft shell technique, the anterior chamber is filled with viscoadaptive sufficiently to blockade the incision. Balanced salt solution is then injected under the viscoadaptive to create a thin aqueous layer on the lens capsule surface, while the eye is pressurized with the viscoadaptive. Capsulorhexis is then easily performed in a pressurized aqueous environment, with no tangling of the capsule and little tendency for it to tear out peripherally. A typical initial phaco slice is demonstrated here in a grade 1 nucleus grossus case, the easiest cases on which to learn this technique. Animation is used to illustrate the technique more clearly. After anterior cortical removal, the phaco tip is buried into the nucleus until it is completely covered and comes to rest just distal to the lens geometric center. The Nagahara chopper then slices the nucleus in two. After rotation, slicing is repeated and the segments are removed. In a harder nucleus, the slice will propagate, often before the chopper even reaches the phaco tip. The Nagahara chopper is buried to its full depth just inside distal capsulorhexis and is drawn to the side of the phaco tip, aiming for the lens center. The slice is seen here to propagate. However, a soft lens is not brittle enough to allow propagation of the slice. In soft lenses, slices must therefore be carried all the way to the proximal edge of the capsulorhexis in order to achieve a good separation. After the initial separation, the lens is rotated with a Nagahara chopper and the distal half of the lens is sliced again. Removal of pieces may either begin as soon as 2 consecutive clean slices are obtained or after the entire lens has been sliced into pieces. Residual cortex is removed with a silicone sleeved irrigation aspiration tip allowing better pressurization of the eye. And the capsule is then polished with jets of balanced salt aimed tangentially at residual cortical fibers. The second step of the ultimate soft shell technique is then used to partially fill the anterior chamber and to blockade the capsular excess. The capsular bag is then filled with balanced salt solution in a manner similar to hydrodissection until the eye becomes firm. Here you see the Acrosoft SA60 intraocular lens injected to the Monarch 2 injector. The distal haptic begins to open as it is an aqueous environment. However, the proximal haptic remains flexed in the viscoadaptive environment. Once the IA is turned on, the intraocular lens falls back completely into the aqueous field capsular bag, making viscoadaptive removal very easy in about 10 seconds using modified rock and roll technique.
Okay, so the points about this are as follows. The first thing is, when you want to do any kind of phacosurgery, you have to balance the pressures inside the eye. So the pressure in front of the capsule and in front of the nucleus should be a bit higher than the pressure inside the capsular bag or in the vitreous, and that keeps everything stable to make life much easier. Next thing is when you do the first slice. The first slice is by far the hardest, and you want to bury the phaco tip just past the geometric center of the nucleus. On the right side, if the phaco is in your right hand, on the left side if the phaco is in your left hand. And then you go and you slice right beside it, so you go towards the center with the chopper. Subsequent slices are done by rotating the lens towards the phaco, away from the hand holding the chopper, and then you just continue to chop them. It's actually much easier and more stable to chop all the pieces before taking any out, and then you take them out easily. Basically, you want to chop the lens into 5 to 8 pieces. I like 5 because I like to do the second half in 3 pieces, with the third piece being small, so that it comes out easily to start the removal of the pieces. But the more dense the lens, the more pieces you can break it into to make it more easily. So the dense lens, I will do 8 slices and not 5. And I like to use continuously variable pulse so that it's very simple to do the surgery. So then, some of the tips. Well, what I like to do now is I like to use this fine cannula, the Akahoshi cannula, to do the hydrodissection, because as you can see, the tip is beveled and it's polished, and so you don't tear the capsule. And at the end of the case before, you saw that I polished the capsule with jets of balanced salt from the cannula. So the smoother the cannula, the less the chance of tearing the bag. It's not very nice or very pleasant to tear the bag after you finish the case. With this cannula, you won't do that. The chopper I use is now the Nickerman chopper. You can see this design of the edge of the chopper where the tips are sharp here, and you can put it into a hard lens, and the paddle is wide, so you can pull apart the pieces quite easily. So I like to use, instead of balanced salt, I use xylocaine phenylephrine solution underneath the OVDs. I like, if you have a more dense case, to lower the vacuum and flow, because the less turbulence you have, the easier the case will be. So I lower the flow and lower the vacuum. And I bury the phaco tip deeply before trying to slice, or else the lens will rotate and doesn't work so well. So that's okay for most of the cases. And here I want to show you what happens in a very soft lens. So I recorded a bunch of them here, but I'll just show you one so you get the idea. The problem with the very soft lens is you can't chop it. So in a patient between, let's say, 35 and 50 years old who comes with a posterior subcapsular cataract, for example, it's actually harder for most people to do this because you can't go through the routine of chopping. So the first thing I do here, you'll notice, is I hydrodissect the lens really, really well. And then I will hydrodelineate it, because the more layers you have it in, the easier it will be to take the center out. And you want the center removed because then you can maneuver the peripheral cortex more easily. And then this very simple technique I'm going to show you is you come in with the phaco tip and you use extremely low power, barely on, and you phaco away the center of the lens and going out to the cortex away from where the entry into the eye is. And if you watch that happen as I get the patient still, you see that the center will come out, and then I put in the Coke rotator rather than a chopper, because I don't want to chop a very soft lens, so I'm afraid of chopping through it. And I just take away the center of the lens there and the periphery in one quadrant. And then I will insert the Koch rotator into the periphery of the lens and rotate it to expose more of the lens towards the phaco-tip. And then if you just aspirate it, it will make the lens flip over and come out of the eye very easily. So this makes soft lenses actually very easy. You've done this part. All you have to do now is change to your IA and do the cortical removal. So next, I'm going to talk to you about doing bilateral surgery. And the big thing in bilateral surgery is how you do the changeover. So I'm going to show you this video about the turnover that we did and we show people all the time. Yes?
We are jumping to another topic now, right?
Okay, do you want to just skip that and discuss questions?
Yeah, discuss some question and to make it a separate one.
Okay, so we can have questions now.
Okay, thank you very much for great and very simple and guiding presentation about the how to do the slicing or separation of the nucleus or the chopping in this minded and scientific way.
Okay, so one of the points I want to make is when you chop, you saw that the first chop, I buried the phaco in to stabilize the lens on the phaco. But for subsequent chops, you actually do better if you just abut the phaco against the bottom half of the nucleus to hold it stable and don't go into it and put the chopper away and run towards it. Yeah. And that way it's much more stable. If you try to go into the nucleus, as you go into the middle and go in further, you go into a less and less dense part of nucleus. So the further in you go, the less firm your grab is going to be. So you're best off after the first chop to just abut the phaco against the nucleus and chop against it.
Yeah, okay. This is what's called the vertical chopping.
Yeah.
Yeah, this is vertical chopping. What about the horizontal?
Actually, a mixture.
Yeah.
It's a mixture because you're going in and you're chopping the center. There's no reason to ever try to chop the peripheral part of the lens because it's soft. As you pull apart the central nucleus, the peripheral part comes apart by itself.
Yeah, okay. So it's different than the usual or the normal way to do a groove, a deep groove, until you can see the retroflex, and then you can divide by an opposing movement. It's different.
Right. I don't like sculpting at all.
Yeah.
Because if you sculpt, one day you're going to start doing pseudoexfoliation patients and you're going to dislocate the lens, and it's an extra step for no benefit.
Yeah, this sculpting or this deep grooving is of two problems. The pressure on the zonules, which may lead to zonular disturbance, even if there's no subluxation, but with big zonules like in an old age and pseudoexfoliation, as you said. The second problem with the beginners who cannot judge the depth of the groove, they may cause posterior capsular hair at the beginning of the surgery, which is a very difficult situation.
The third problem is that you're removing the most dense central part of the lens, which is the part that enables you easiest to chop if you hold it.
Yes.
So once you take it out, you then make all of your chopping more difficult.
It's the core of the lens.
Right.
So yeah, it helps division.
Right. So you just made your operation much harder by taking it away.
Okay. What about the diameter of the rhexis in such cases? If you have a big nucleus, it's easy to do it with a 4.7 millimeter diameter of the rhexis.
As far as I can tell, surgery is always better when you leave it 4.7. Because if you make it bigger, although you can take out the nucleus, or the first step may be seeming a bit easier, afterwards your operation gets much harder.
Yeah.
And if you ever break the capsule, you can't capture the lens in the rhexis. They just asked me to look over a court case where someone could not capture a lens in the rhexis because it was too big and they broke the capsule. And then what happens is the lens that they could get that they had in the hospital was too small. And so subsequently, by putting it in the sulcus, it decentered and the patient had problems and it ended up as a court case.
Yeah.
So I just think that it's not a good plan. You're always better off to make your Rexus 4.7, maybe 4.8, but not big. Always less than 5. I personally like 4.6. If you ever try to capture a lens in 4.6, it's really nice and tight. You can then go back with your IA and take out viscoelastic. The lens doesn't move, and it makes your operation much easier.
Okay, but let me ask about one of the common difficult situation with the brown, the dense brown or the cataract negra. If you are doing slicing and separation with this technique, what about your experience in such condition? How to do it in an easier way? Usually, I found that the dense brown cataract or the cataract negra is like amalgamated. It's not easily.
Right. It's hard to pull it apart.
Yeah.
So what you do, you find that you start off the same way. You bury the phaco tip into it. You take the topper, and the Nikon is great because the corners are sharp. So when it has sharp corners, you can push it into the nucleus better than other toppers. And so it gets in deeper. And then as you divide it and you take the topper and go in deeper and deeper because it won't go all the way the first time. And after, like, you're sitting there and holding the lens and going in deeper and deeper, you find that you're down close to the bottom. If you don't get at the very bottom the first time, don't panic. Rotate the lens to the second piece. The second piece will always go to the bottom because you have now a better hold and you can flex down and get deeper with the chopper. Because remember, the second piece, you're only doing half the lens. You're not going in the middle of the whole lens. And so because you're going into now, by definition, a less dense piece of lens, because you're starting from the middle, which is the most dense, and going to the periphery, which is less dense, you can get in easier and you can separate it better. And then in those dense cataracts, I always chop them into 8 pieces. You can't chop more than 8 because the diameter of the phaco makes it so that you really can't get enough space to get more than 8 pieces in. So you do 8 and you cut it and you keep going around and around. And usually every successive chop, you get deeper and the split becomes better. And then as you finish that, you just go and you take out 1 piece at a time, starting with the one that's most easy to get out. And then you go along and take out the ones that are more difficult. Because every time you take out 1 piece, the subsequent ones become easier. And I still keep the Rexus at 4.7. Another one of the reasons in dense cataracts to keep the Rexus at 4.7 is you find that when you do a good hydrosection, the lens is then well stably confined into the bag, and you can rotate it and do things, and it won't pop up and twist and get caught. It just stays in the plane where you want it to work.
Thank you, but before closing the discussion about this issue, I will ask you about the chip and the flap. What's your opinion in soft cases? In some soft cases, I may do what's called debulking by emulsification or decreasing the center core of the lens to remove all the center bar. Then I flip it by the chopper or by the phaco tip itself, flip it in the pupillary plane, and then aspirate it. What's your opinion about this?
So it's similar to what I showed. The problem with soft lenses is there's infinite variation. You know, from a child where you just aspirate it to someone who's, let's say, 50, and the lens doesn't really chop. The chopper slides through, it doesn't really come apart. But it really is not solid enough to phaco properly. And so there's variations between what I showed you in a more soft one to one that's more difficult. But the general idea of taking out as much of the center as you can and rotating it with a gentle rotator, like a Coke rotator, and keep taking more. Once you get more than half of it out, the rest will just fold up and come out.
Yeah.
So, you know, there's variations on how, but that technique was sort of a general idea of how you do them. And it's actually always works for softer lens, and it's much safer than trying to phaco against the posterior capsule.
Yeah, okay. And
if you put the power up, it's going to go right through the lens and through the capsule.
Yeah, this will be helpful in different degrees of soft lenses. We are talking about these soft lenses, like in the clear lens extraction, but also you may face this problem with the less dense cataract, like the nuclear grade 1, the anterior cortical, the posterior cortical cataracts. All these are considered as a soft lens with no bulk, no central bulk. So you will try to get it by this way. Otherwise, you may catch the posterior capsule and go in troubles.
So among the patients I get sometimes, I get people that are, let's say, commercial pilots who end up having to take prednisone for some disorder they have for a while. And they come with a posterior subcapsular cataract where they can see 20/20 walking around, but they can't see to land their plane facing into the sun. The pupil gets small. So that you can't let a commercial pilot be like that because he has to land the plane. So you're doing, 40-year-olds with basically very soft lenses, but a posterior subcapsular opacity that affects their flying. So you don't want to break his capsule because you're going to destroy his career. So this technique I've developed, I find it just much safer, and you can be very gentle and rotate it, and it comes out easily. But again, the more you hydrodissect, the easier it's going to flow into the phaco and come out with less energy.
Yeah, okay. Perfect. Thank you very much for this nice and fruitful discussion about this topic.
You're very welcome.
We are so glad to have you in our Ziada Eye Academy and this Zoom meetings about the most common thing in ophthalmology and subject in our career, the cataract surgery. Thank you very much, Dr. Steve Arshinoff, Professor of Ophthalmology, Toronto University, Canada.